Assalamu alaikum everyone. My name is Dr. Maluk and I will be presenting the today's core urology lecture with the topic of treatment of the erectile dysfunction, and my moderator is Dr. Zuhair Zafar, replaced by Dr. Noman. So the content of my presentation consists of the general measures, psychosexual therapy, drug therapy, vacuum devices, and surgical treatment options for the erectile dysfunction. First, we will discuss about the causes of ED, which consist of the psychogenic causes, vasculogenic causes, which might be arterial or cavernosal causes, hormonal causes, neurogenic causes, and other causes such as old age, diabetes, and CHD. Psychogenic cause can be due to the performance anxiety, a loss of attraction with the partner, and having multiple previous failures, anxiety, and depression. Vasculogenic can be due to the atherosclerosis and trauma and prolonged hypertension. Hormonal causes can be due to the hyperprolactinemia or hypogonadism. Neurogenic causes can be due to the Alzheimer's disease, spinal cord injury, radical pelvic surgeries. This can lead to the neurogenic causes of the ED. Drugs such as the antihypertensive, anti-androgens, and antidepressants drug can cause ED.
Every system is controlled by, every organ is controlled by 2 or 3 basic systems. The first thing is arterial blood flow, inflow and outflow. The second thing is neuro central nervous system or peripheral nervous system. The third is hormone, can be exocrine, can be endocrine, or the organ can itself be a hormone producing organ. The ability to maintain an erection so that a male partner can penetrate depends on the normality of all 3 or 4 functions. If there is a depression, or if there is anxiety, or if there is any other like Parkinsonism or other neurological causes, patient can have ED. So the organ consists of multiple things. All things can be the cause. Etiology, and it is said that the normal human male, without having any libido or any other wish, he can have erection in 24 hours, about 11 to 18 erection normal, without any. But there's another beautiful thing, that ED can be the first symptom of future heart dysfunction. It might be the first vessel that can be affected from atherosclerosis, affected from any neurological disease. So the cause is itself inside the organ. So whenever there's a question in exam, you can classify accordingly the systems. You can classify according to the signs, or you can according to the comorbidities. So it is.
This is a treatment algorithm for the patient with present with the ED. First, we have to have a comprehensive medical and sexual history. We have to assess a detailed etiological framework before any therapeutic intervention, identify the patient needs and desires, and identify the curable causes of erectile dysfunction, such as anatomical causes. There can be anatomical causes, hormonal causes, psychological causes. First, we have to treat the curable causes. Second is the lifestyle modification. Third, patient counseling and education. So the treatment options consist with the oral therapy with the phosphodiesterase inhibitors, intracavernosal injections, and intraurethral devices or injections, and vacuum devices. So first, identify the curable causes of erectile dysfunctions. If there is a curvature, we have to treat the curvature. Psychological assessment should be done before a treatment. And it's important to tell the patient that ED can be treated successfully with the current options, but it cannot be cured, with the only exceptions that psychogenic ED, post-traumatic arteriogenic ED in young patients, and hormonal causes can be treated with specific treatment options. Lifestyle changes or modifications consist of the smoking cessation, reduced alcohol intake, and weight loss, and regular exercises. Psychological therapy, even if the cause of erectile dysfunction is physical, the patient might develop the psychosexual issues. So the patient should be referred to the psychosexual therapist and have a relationship counseling and centered focus exercises. Treatment algorithm consists of the oral medications, intracavernosal and intraurethral. Oral consists of the phosphodiesterase inhibitor, phentolamine, and apomorphine, and yohimbine. Intracavernosal consists of the prostaglandin E1 and alprostadil, and papaverine, and intraurethral consists of alprostadil. This is the this flow chart showing the commonly used drugs which are FDA approved for the treatment of the ED in men First is the sildenafil, which came with the market name of Viagra, with the formulation of the 25 mg, 50 mg, and 100 mg. It has a maximum dose of 200 mg, and sildenafil should be taken 1 hour before sexual activity and having a half-life of 30 minutes. Vardenafil, which comes with the formulation of brand name of Levitra, with formulation of the 5 mg, 10 mg, and 20 mg with maximum dose 20 mg. It should be taken 30 minutes before sexual intercourse. Tadalafil Cialis, which came with the formulation of the 5 mg, 10 mg, and 20 mg. Avenafil, which came with the formulation of brand name of Sprenda, having a formulation of 50 mg, 100 mg, and 200 mg.
What is the mechanism of action of phosphodiesterase inhibitor? How? Parasympathetic. So a proper affection, to have a proper affection, the mind and body should be at rest. There should be no sympathetic drive. So whenever the patient is in stress, or whenever the person is in great hurry, in fight or flight mode, there will be no erection. So whenever there is a test called nocturnal plant emissions and rigidity test. So it is basically based on this neurological phenomena that when a person is in rest, he will have the morning erection, he will have the night erections. Why? Because the body is at rest, but the parasympathetic, which is actually, we can say that it is a rest phenomena. So it can be this.
Here is a short video which shows the mechanism of action of the phosphodiesterase, which is used in treatment of erectile dysfunctions.
Sexual stimulation causes release of nitric oxide from endothelial cells and nerves directly into the penis. Fine, and this nitric oxide is a vasodilator which acts by increasing the level of cyclic GMP in the smooth muscle cell. Nitric oxide reacts with guanylate cyclase enzyme into the smooth muscle cell, and this interaction results in the synthesis of cyclic GMP from guanosine triphosphate. Now, the cyclic GMP can be hydrolyzed to the 5' GMP by phosphodiesterase 5 enzyme. But as this sildenafil is the phosphodiesterase 5 inhibitor, so there will be the increased level of cyclic GMP in the penile arterial smooth muscle. And this increased level of cyclic GMP will activate cyclic GMP dependent proteins kinase G, which results in decreased in intracellular calcium concentration. As there is a decrease in the calcium concentration, so there will be no phosphorylation of myosin molecule by myosin light chain kinase enzyme, and it results in arterial smooth muscle relaxation, which results in increased arterial inflow in the corpus cavernosum, which results in penile erection.
So this was the mechanism of action of the phosphodiesterase inhibitor. So here is a comparison of the different phosphodiesterase inhibitor, which I discussed previously. In the oral dose, maximum dose of Cialis is 20 mg, Levitra is 20 mg, while the Viagra is 200 mg and Avenafil is 200 mg. Peak time to median time to achieve the peak concentration of the Cialis is 20 mg, Levitra is 40 to 60 mg, Viagra is 60 mg, and Avenafil 30 to 45 minutes. Half-life of the Cialis is 17.5 hours, and Levitra 4 to 5 hours, 3 to 4 hours of the Viagra, and 6 to 17 hours. No any drug have an interaction with the alcohol. These are the
So one thing that you might have seen in the previous slide, if you go back to the previous slide, you can see there are some phosphodiesterase inhibitors that have more half-life as compared to the others. For example, tadalafil is the one that has the median time to peak concentration, that is 120 minutes. So these kind of phosphodiesterase inhibitors are usually prescribed to people who want spontaneity. Also used in older patients having erectile dysfunction with BPH. So this is a drug of choice for those patients. All the other ones, they have much more shorter half-life. And as you can also see that the half-life of tadalafil is 17.5 hours. But the median time to peak is 120. However, all the other ones, they basically peak earlier and they do have a shorter half-life. One thing that is missing over here is how to take phosphodiesterase inhibitors. How do you prescribe patients phosphodiesterase inhibitors and tell them how it should work? It's just not the fact that you can just give them a pill and then they would swallow that pill and that's it. So basically first counsel the patient before starting a phosphodiesterase inhibitor. You need to take a proper history first, because history is important. I'm sorry I'm a bit late. I would have talked about the history, because history is very crucial regarding erectile dysfunction, because because of the advent of social media and all the open sources platform, there's a lot of expectations that the patients don't really meet, because they have sort of like expectations for what they can actually do, especially the younger age group. I was in the OPD the other day, and there was this like a 21, 22-year-old kid. I would say he was a kid, and he was about to get married, and the expectations that he had from his sexual life was, it was astonishing. It was very surprising. Although he did not have apparently erectile dysfunction, but the stress and the anxiety was taking a toll on him. And he would say that I would kill myself if nothing happens or something like that. So people are really, really touchy, and they get mentally and emotionally drained. So before everything, before starting any medical therapy or surgical therapy whatsoever, you need to take a proper history. PD without a proper history should be criminal, I would say that, because this is directly related to a person's life. So over here, you need to make the patient understand, especially if you are now onto giving PDE5 inhibitors, first take a proper history, and then you need to tell the patient that when should this particular drug be taken, right? And what are the food interactions? Usually, a lot of phosphodiesterase inhibitors, they don't work well with high fatty foods. That should not be taken. It should be taken 1 hour before, and you have to make the patient understand that there are consequences, that there are side effects of taking these drugs. And it should only be taken 1 dose a day. The patient should not repeat that particular drug 2 times a day. So this is very important when you are basically prescribing the patient the PDE5 inhibitors. So yeah.
Here is the adverse effect of the phosphodiesterase inhibitors. So adverse effect comes of the headache, flushing, dyspepsia, abnormal vision, and nasal congestion. The most feared complication is NAION, non-arteritic ischemic optic neuropathy, which is the feared complication of these 5 phosphodiesterase inhibitors. So phosphodiesterase inhibitor safety issues: cardiovascular safety, sildenafil, tadalafil, and vardenafil cause no increase in myocardial infarction rate, while it's contraindicated in patients who suffer from myocardial infarction, stroke, life-threatening arrhythmia within the last 6 months, having hypertension and hypertension, unstable angina. It's also contraindicated in patients taking nitrites, as these nitrite causes result in increased cGMP accumulation and unpredictable fall in the blood pressure, and results in the hypotension. So phosphodiesterase inhibitor are contraindicated in the recent cardiovascular events, patient taking nitrites and having hypotension, patient with anatomical deformities such as angulation, cavernosal fibrosis, and Peyronie disease, and patients who are predisposed to prolonged erections such as sickle cell anemia, multiple myeloma, and leukemia.
Anyone would tell me why are these contraindicated in anatomical deformities? I think it's a very, very common answer that I'm expecting from the audience, I believe. Anatomical deformity में क्या होगा? Clear है? क्यों work नहीं करेंगी? क्यों? What is the reason? There has to be a reason, right? Well, if there is an anatomical deformity, for example, there's a Peyronie's disease and the patient takes it, and even if there is an erection, for example, but the patient does not achieve that particular result, then obviously you would think that it's not working. So obviously you can't just hand out candies to the patient like this.
Centrally acting drugs consist of apomorphine and yohimbine. Apomorphine work by acting centrally acting drug that improves erectile dysfunction by enhancing the central natural erectile signals. It is a non-selective dopamine receptor agonist and acts mainly on D2-like receptors into the brain. Yohimbine is a centrally acting alpha-2 adrenergic antagonist. Intracavernosal injection. These injections are given to the patient not responding to oral medications, and these are very safe and highly effective. Here is a short video of how to insert intracavernosal injections.
Blood vessel. Imagine the shaft of your penis is divided in 3 parts. You'll give the injection in the middle part at the 10 o'clock position on the left side, or the 2 o'clock position on the right side. Switch sides each time you give yourself an injection. This helps protect the tissue. Never inject straight into the top or bottom of your penis, and avoid any veins you can see or feel. Injecting into a vein could cause a large bruise. Once you've chosen the injection site, open.
So injection should be given at the lateral aspect of the penis at the 2 and 10 o'clock position to avoid injury into the main veins.
So who should be prescribed these cavernosal injections? Anybody? And how do we know that they have failed these oral medication trials?
There's a time duration for which we give oral medications,
Mhm.
and before prescribing intracavernosal, we also know that whether patient is taking it rightly or not. He is taking it properly, and second, compliance. We have to see these things also before prescribing intracavernosal injection or second line treatment.
Yes. So you need to reevaluate the patient once he comes back to you that, Dr. Saab, you have prescribed this drug and it's not working on me. So you just don't have to shoo the patient off. You just can't tell them, okay, fine, just start intracavernosal injection, because this is an invasive procedure and that has its own complications. So what we need to do is we need to take a proper history that how the patient is taking those drugs and how it's being administered, if he's compliant to those drugs, what is the duration now, what are his expectations out of these drugs. Sometimes it is probably working, but the patient has unrealistic expectations, because this is something that is very commonly seen during, when you're evaluating the patient. So firstly, if you have actually evaluated the patient properly by doing a physical examination or as well as taking a proper history, only then you advise the patients to get intracavernosal injections. And especially patients who have problems like medical conditions like diabetes and hypertension. Mostly we have seen that PDE5 inhibitors don't have a very good, don't work all that well. So for those patients, because intracavernosal injections, they work directly. You inject them and directly there is a response. So these are the patients who should be prescribed intracavernosal injections. One who fail PDE5 inhibitor trials, and the other one is patients who have medical conditions like diabetes or hypertension mostly.
Most commonly used intracavernosal agents are the alprostadil, which came with the market name of Caverject or Edex, with formulation of the 5 to 40 micrograms. It is a prostaglandin E1 like agent which increase cyclic GMP, which is a vasodilator and smooth muscle relaxant of the corpus cavernosa and trabecular smooth muscles, and it's called the erection, and it has a success rate of 70 to 75%. Pepaverin, which come with the formulation of the 15 to 60 mg, which works by inhibiting the phosphodiesterase into the smooth muscles of the corpus cavernosa, increase the cyclic GMP, which causes the relaxation of the vascular smooth muscles and leads to erection. Other agent is the phentolamine, which work by blocking the alpha-adrenergic receptor into the penile blood vessels, causes the relaxation of the trabecular cavernous smooth muscles and dilatation of the penile arteries. It has a weak effect when used alone. It's most commonly used in a combination with Biomix and Trimix. Biomix consists of pepaverin and phentolamine, while Trimix consists of the pepaverin, phentolamine, and alprostadil. Adverse effect consists of the priapism, fibrosis, hematoma, penoscrotal pain, while the contraindications to this are the hypersensitivity to alprostadil, bleeding disorder, and patient having a risk of priapism. So here is a comparison of the different groups. As I mentioned, that alprostadil having a maximum dose of 5 to 40 microgram per ml with efficacy of 70%, having adverse effect of the priapism and fibrosis. Pepaverin having a maximum dose of 20 to 80 mg with the efficacy of less than 55%, which also have adverse effect of priapism and fibrosis. Phentolamine having a dose of 0.5 mg per ml, poor efficacy as used as monotherapy. It causes systemic hypotension and nasal congestion. Papaverine, Bimix and Trimix having an efficacy of the 90 to 92%, having a similar adverse effect as alprostadil.
So one thing that you should know, maybe the examiner would ask you in the examination, you might have heard about the bimix and the trimix as well. You need to also have the information that these are still not FDA approved. So you can't just prescribe them like this. But usually in clinical practice, they are being used by a lot of centers. But one of the stigma that is related to this is that they are still not FDA approved, because pepaverin on the whole is not FDA approved by itself, and this mixture contains that. And the other one is also phentolamine, that is also not FDA approved for the treatment of ED. So both of these compounds, they have both of these substances in it. So hence, trimix and bimix are not FDA approved, and you cannot just use them in open clinical practices like that.
Intraurethral treatment option consists of the alprostadil, which is commonly known as the Muse, with formulation, which came with the formulation of the 125 mg, 250, 500 mg, 1 gram. It is alternate treatment options for the patient who are not willing for the intracavernosal injection and prefer the less invasive treatment options. In this, a pellet is inserted with the applicator and leave this pellet inside the penis to get it absorbed. While it has a side effect that causes penile pain, dizziness, and priapism, which is a rare complication. So vacuum devices treatment of option in a well-informed patient with infrequent sexual intercourse and comorbidity require non-invasive drug-free management option for the erectile dysfunction. Satisfactory is as high as 90% of the patient without bleeding disorder and patient take with anticoagulation therapy. In this, blood is trapped into the intracavernosal and extracorporeal compartment of the penis, which have a maximum time duration of 30 minutes, having complication of cyanosis, edema, and the cold. Here is a short video how to use these vacuum devices.
This is the VacuRect. The VacuRect is a vacuum erection device that mimics the natural erection process by drawing the blood into the penis for you. Once you achieve the erection, our patented tension system will maintain the erection as long as it is in place. The VacuRect is 9 inches in length and 1 3/4 inches in diameter at the opening. The first thing you will do is start with the largest size tension system and place it on the opening of the cylinder. It will fit on the opening just like when you put a lid onto a coffee cup. You will then place a small amount of lubricant on the head and the shaft of the penis. Rest the head of the penis at the opening of the tension system. Slide the sleeve up and down to create the vacuum pressure. The head of the penis will begin to be drawn through the tension system and into the cylinder as you achieve the erection. Once you achieve the full erection, you will press the edge of the tension system to release the vacuum pressure. Remove the cylinder, leaving the tension system at the base of the penis to maintain the erection.
So these are mostly used for patients who are older and have medical conditions, who can't take PDE5 inhibitors and intracavernosal injections. They're not very reluctant to take. They're very reluctant to take that. So you can ask them to have this penile pump, which I would say constriction devices, and the ring at the end when the vacuum is achieved and the penis is erect. You need to understand that you need to tell the patient that you need to remove that particular ring at the base of the penis that is providing that sustained erection within 30 minutes. Otherwise, adverse events can take place, like skin necrosis and edema and stuff like this. So he's already written these down. You can see that there's pain, there's inability to ejaculate, then petechian bruising. You can also see on the penile shaft and the head some numbness as well because of the constriction of the nerves, and the skin necrosis. And like this, what Maluk has mentioned, that you need to remove the constriction ring within 30 minutes. So this is very important when you are prescribing a patient treatment like this.
Yes, and I think nobody amongst the audience has ever seen such case these days. But 20, 25 years back, when I was at your age, these kind of cases do come to our emergency unit, and they have got one problem, and that problem is that somebody from the manufacturer side or the pharmaceutical company, they directly contact the patients, and they try to demonstrate the whole process, missing the point that you have mentioned at the very last, that is the ring, how to remove the ring, how important the ring is, and then the patient uses it whenever the patient feels to use it. And normally there is no point where the patient can stop it. So always there is a point of overuse of this vacuum device, so that the penile shaft is swollen so much that the ring is actually not seen at all. It is burrowed down into this fold of the skin. So when these cases come into our emergency unit, we always, at that time, everybody of us knew how to remove these rings. The first and foremost thing is to do some cold compressions, and this cold compression usually is done at the base of the penis, so that you can see the ring, and then the ring is cut through. That ring is actually broken down by maybe pair of strong scissors or things like that. Otherwise, if you use a scalpel or the knife, then you are directly into the base of the penis. So it will be an injury, very devastating injury. So these are the cases that do come to us looking like a priapism. It isn't a priapism. So you have to have that kind of knowledge, and that knowledge comes through taking a proper history.
So we see a lot of younger patients with mental disorders do that. They put that metal ring at the base of the penis. It's just not the fact that a lot of pharmaceuticals are promoting it. I don't know where they get this information, but I think recently on my last call, I just got this, a young chap. He was around 25, 26 years of age, and he had the similar problem. He put a ring at the base, and he had this for like I think it was like 2.5 hours when he took the history. So 2.5 hours after that, the penis was turning black. There was a lot of edema, and the patient was in a lot of pain, but he could not get it removed because of the engorgement of the penis. So this is usually what happens. It's a very common clinical scenario that you would see in your urology residency or in your consultancy.
Yeah, those rings are actually inadvertently put on.
Yes.
But they are not actually part of the device.
Yeah,
I'm talking about the device, because whenever this device comes in, it's not something which is like over the counter sort of device that you just buy it on your own from any chemist's shop. So probably you always contact someone over the telephone, and that person comes to you at your home, deliver it and demonstrate it. So this is the kind of the whole circuit that goes on. So in that circuit, what is actually missing is something called removal of that ring. So that is very important.
So the next option consists of the penile prosthesis. Patient who failed with the pharmacological therapy and have a permanent solution to the ED. So penile prostheses are broadly divided into two classes: inflatable and semi-rigid. Inflatable are further divided into the 2-piece and 3-piece, while the semi-rigid are further classified into the three types as mechanical, soft malleable, and flexible. So surgical approaches are the penoscrotal and infrapubic approaches. Penoscrotal got the excellent exposure, avoid dorsal nerve injury, direct visualization of the pump placement, while the infrapubic approach that it insert the reservoir under direct vision, having a low risk of dorsal nerve injury. These got the complication of the mechanical failure and infection. Here is the video demonstrated how to insert the penile prosthesis.
You are positioned carefully. An incision is made. This can be above the penis, on, or under the scrotum, depending on your body and your surgeon. The corpora cavernosa are gently dilated and measured using a probe. Your surgeon selects an implant size to fit your penis. The implant cylinders are then placed in the corpora of the penis. Your surgeon now puts the reservoir in your belly, behind the muscles of your abdomen. Sometimes, to get to this part of the body, a second small incision is needed. The pump is placed in your scrotum. Your implant is tested during surgery to be sure that it is working properly. To make an erection, the pump is gently squeezed. To relax the erection, the pump is squeezed again.
So these are the type of processes I have mentioned earlier: semi-rigid and inflatable. So there is
Yes. So you have seen a bit of how these penile prostheses are inserted. It was a very short video, but these are very important, especially for the residents, because they usually get these in their OSCE examinations, the penile prosthesis. So you need to understand there are different type of penile prosthesis as well. Number one, it's the one is a semi-rigid, which, to be honest, I have not seen very commonly. But the other one is the inflatable devices that we usually the patients do have, and they come in two types. It's a two-piece device and it's a three-piece device as well. So anybody who care to tell how these the two-piece device and the three-piece device differ, and why one should have a two-piece device or a three-piece device rather than a two-piece or three-piece device? How do you decide that you need to put a two-piece device, and how do you decide you need to put a three-piece device in the patient? Anybody from the audience?
Two-piece and three-piece devices are different in the sense that the patients who are having history of lower abdominal incision or any lower midline incision or any surgery like laparotomy, which involve the incision over the lower midline, so we will be unable to reach the radius space. So it will be difficult to place the three-piece device in that patient, those patients.
So why is it difficult? What is the difficulty that you would face?
Difficult to achieve the radius space, and the adhesions also due to the surgery previously taken.
What is placed inside that particular cavity? I mean, there's a reason why it's a three-piece and a two-piece device, right? Okay, so basically a two-piece device is not the gold standard. The three-piece device is usually the gold standard, because as you mentioned, that a two-piece device is usually inserted once the patient has a history of any pelvic surgery because of the fibrosis that is going on, because you need to put the reservoir inside that particular cavity. But in a two-piece device, the reservoir and the pump, they are both in the scrotum. But the problem with a two-piece device is usually that when you need to deflate the penis, then you can only achieve around 40% of deflation, because not the complete amount of fluid that is present in the reservoir stays there. There's a bit of it in those tubes as well that you insert. So hence, having a three-piece device is more, preferable as compared to a two-piece device. But the only reason, like you said, that a three-piece device is not inserted and a two-piece device is inserted because of the pelvic incision or any pelvic surgery that has been done, in the previous surgeries. So this is important point. Maybe the examiner would ask you regarding this.
Here are some recommendations to treat the patient with the ED. So first, we have to assess the patient for the inadequate or correct information about the mechanism of action and the way in which the drug should be taken, and the main cause of lack of response to phosphodiesterase inhibitor. The use of cognitive behavioral therapy as a psychological approach in patient with the psychosexual option. Initiate the lifestyle changes and risk factor modification prior to and at the same time as initiating the erectile dysfunction treatment. So first line is to treat the phosphodiesterase inhibitors and use intracavernosa injection as an alternative first line treatment option in a well-informed patient or as a second line treatment therapy. Use vacuum erection devices as alternative first line therapy in a well-informed patient with infrequent sexual intercourse and patient with comorbid requiring non-invasive treatment options. Use implantation of the penile prosthesis if all other treatment fails or depending upon the patient's preferences. Discuss the patient with underlying radical prostatectomy about the risk of sexual changes other than the ED, including libido reduction, changes in orgasm, in ejaculation, Peyronie disease-like, and penile size changes. Data is inadequate to support the use of any specific regimen for the penile rehabilitation after radical prostatectomy or pelvic surgery. Thank you.